Now, moving on to our next section, we have discussed the Colles fracture, but now we'll be discussing the volar displaced fracture or the Smith fracture and the Barton fractures. In this section, we briefly going through the volarly displaced fractures or the Smith fractures. What includes the fracture of the radial styloid, and what are the Barton fractures which have intra-articular extension, and what are their features, X-rays, and how they are treated. So we have discussed briefly in the first section about the Colles fracture, which was actually a fracture resulting in a dorsal displacement of the distal fragment. But when the patient falls on the outstretched hand in such a way that the forearm is supinated and wrist is flexed, this results in usually a fracture resulting in a Smith fracture, in which the distal fragment of the fracture gets volarly displaced. So a fracture in which the distal fragment is angulated or displaced volarward, also called as Smith fracture. It's usually called by a fall on the back of the hand, unstable injury due to force, and generated by long fracture crossing the wrist joint. FDS and FDP are actually crossing the wrist joint, and they can be the very important deforming force which could be acting on this fragment. Now the carpals are actually slipped forward with anterior block of the bone, and volar half of the distal radius fracture can shear off and fragment moves forward, leading to carrying carpus with it, sometimes called as Barton fracture. So it's important that usually the Smith fracture is extra-articular, but sometimes when this shears off, this can lead to intra-articular extension, leading to a Barton fracture. And when this fracture is actually going volarward, we call it a volar Barton. Sometimes even the Colles can go as well with an intra-articular extension, but when that fragment is actually sheared off dorsally, this becomes the dorsal Barton fracture. Now coming to the clinical features. Clinical features include wrist injury. There will be definitely swelling, there will be pain, and there may be associated painful range of motion. Although with the Colles you have classically dinner fork deformity, but with the Smith fracture this is called as a garden spade deformity. If you see it from the laterally, it becomes a garden spade in which the distal fragment is going volarly, the proximal fragment going dorsally, and it makes the wrist is then again going volarly, and this makes a garden spade deformity over the wrist joint. Now coming to the X-rays. The fractures through the distal metaphysis is usually seen, as you can appreciate it over here. If you see this X-ray, it looks the fracture is probably going in intra-articularly as well, and this is displaced, and this is definitely looks like, and there is a fracture right in there going in as well. Now this is classically a volar Barton or Smith type fracture in which the fragment has sheared off and gone intra-articular extension, as well as volar displacement of the distal fragment can be seen as well. So that is important. In AP and lateral way, you have to look at whether the fracture is present or not, or is there any intra-articular extension or not, and where is the distal fragment going. It is going dorsally or volarly. So entire metaphysis can be fractured, can be an oblique fracture, a shear off fracture as well, which can exit dorsally or volarly. And when it exits dorsally, it causes a dorsal Barton. When it exits volarly, it becomes a volar Barton. So the treatment is usually by reduction. The first and foremost is close reduction under either GA, or it could be under the Byers or axillary block. So the mechanism for the Colles was that we had actually a wrist was extended with the forearm was pronated, but in this the supination and extension of the wrist is done. Forearm is immobilized with a cast for 6 weeks. To advocate urgent surgical intervention sometimes is required, especially if they actually have 2 weeks. Usually the shear of fracture it redisplaces, so therefore sometimes we have to treat it with surgery as well. And the best method is, and most commonly as it's a volar displacement, so you have to treat it with a volar plate. But if it would have been a dorsal displacement, then you have to treat it with a dorsal plate. X-rays are usually taken at 7 to 10 days just to see whether the volar fragment has displaced or not. If it has displaced, then we may have to go for open reduction tunnel fixation with the volar plate and remove the plaster altogether. Risk of redisplacement is always high, and attention should be paid to the fragmentation, especially the volar ulnar lip of the fragment. Now another common fracture is a fracture of the radial styloid. As you know, the distal radius of the anatomy, this is the radial styloid, and it's making a joint with the carpal bones. Then this is especially the scaphoid. Then this part of the radius is actually making part of the lunate, and then you have radioulnar joint as well, a distal radioulnar joint. It was caused by the enforced radial deviation of the wrist and may occur after a fall when starting a handle or kickback, so that is called as a chauffeur's fracture. In 1920s and 30s, the car had a kind of a gear actually to start the car, and the chauffeur has to actually rotate it quickly so that it actually gives off enough energy. Instead of having an accelerator and a key, they had that kind of a thing in which they had to quickly rotate it so that they can start the car. But what happened is, sometimes in winter, it was actually jammed. So when the chauffeur was trying to rotate it, suddenly stopped, and in this stopping of it, the maximum force was actually that rotating force which was generated by the chauffeur's arm. Instead of going to that handle, it got transferred to its own wrist. This resulted in a classically type of fracture of the radial styloid, and that is why historically it's still been called as chauffeur's fracture, although it's not that common nowadays, especially with we have a keyless start of the car engine, so we don't have to worry about that kind of thing nowadays. But historically it's still called as chauffeur's fracture. The fragment is often undisplaced, sometimes it's going to be displaced as well. The fracture line is sometimes, as you can appreciate over here, it's an oblique fracture line, or it could be a transverse fracture line which is exiting through the radial styloid, extends laterally from the articular surface of the radius, as more commonly it's on the radial styloid side. This is the kind of a thing. If you see this is the x-ray, if you appreciate over here, this is an oblique line which is actually resulting in radial styloid fracture. Injury commonly associated with carpal ligamentous injury. Why? Because nowadays when we have a radial styloid fracture, the mechanism is such that usually associated with ligamentous injury. Energy transfer actually breaks the radial styloid, can rupture the scapholunate ligament. Similarly, can also fracture the scaphoid. If you see, this is the radioscaphoid fossa, which is actually the radial styloid articulates with the scaphoid, with this part of the radius articulates with the lunate. So if the fracture line has fragmented this part, the energy could have been transferred to the radioscaphoid ligament, or it could be associated with the scaphoid fracture as well. Now coming to the treatment. If it is displacement is reduced, how it is reduced? By close reduction and maneuvers under the fluoroscopic guidance by using a Bayer block or a hematoma block, or even axillary block as well, with the wrist held in ulnar deviation by a plaster slab. Why you need to keep it in ulnar deviation? So that by keeping it as radial deviation, there will be further impaction of the radial styloid and it's going to move more laterally. So you have to keep the ulnar deviated. Extending from below elbow to the metacarpal neck, imperfect reduction can cause osteoarthritis. So if we are unable to reduce it by close means, we have to open it and do open reduction internal fixation. It may require a screw to the distal radius or in form of K-wires as well. So if the closed fragment is perfectly reduced and held with, it should be held with the K-wires. If we are unable to reduce it, then we may have to go for closed reduction internal fixation with K-wires, or even the buried cannulated screws as well, because this fragment has to be involved to make it that the articular surface should be less. There should be no articular step, and articular surface, if there is, should be less than 2 mm. Associated ligamentous injuries sometimes need to be addressed, so we may have to, instead of going for closed reduction internal fixation, we may have to go for open reduction internal fixation as well. In this section, we briefly discuss the two different types of fracture. One is the Smith's fracture, or which is actually sometimes called as Volar as well, because there is a fall on the flex stand with the forearm is supinated and a fall on the back of the hand. The fracture fragment can shear off and can be displaced volarly, forming a volar fracture as well. Usually it can be easily manipulated and closed reduction can be done and plaster can be applied. Another form of the fracture we have discussed is the chauffeur's fracture or the radial styloid fracture. Nowadays, the mechanism of energy is such that we have to be on the lookout for associated scapholunate ligaments and associated scaphoid fractures as well. Normally the treatment is actually the closed reduction internal fixation with either K-wire or a screw, but sometimes for other associated fractures we may have to go for open reduction internal fixation of the radial styloid fracture. Thank you very much. Keep watching sqadia.com.